Thank you. Thanks to all of you. Thank you, Cesare. Thanks, Letizia. And David for the invitation. It's always nice to be here. I feel at home here because it's warm, the traffic is crazy, and people is passionate. So it seems like I haven't left Sevilla. It's like being at home.
Treatment of class 3 traditionally has been approached with the so-called classic protocols. In recent times, novel therapeutic approaches have been incorporated into the armamentarium or the orthodontist. So we have enlarged the therapeutic possibilities for early class 3. So the first question is, what to do with our next patient? How are we going to treat our next patient? And not only what are we going to do, but why? In other words, what do we make our decision on? Certainly there are different parameters. I have decided to choose efficiency, efficacy, applicability, and stability. Okay, the classic protocol has been traditionally used in severe conditions, even in the preliminary, I think it's a large, the slides. Do you see the slides okay? Yeah? So I see distorted here. In the early dentition, like in this patient where we can identify clear signs of maxillary hypoplasia, and when we look at the intraoral malocclusion, we see a severe class 3 with an anterior crossbite affecting all the anterior teeth. And we decided to treat the patient with a classic protocol of, you don't see the text.
Expansion, we do.
No, the dates.
You don't see the text.
No, the dates.
Oh,
We don't see the
whatever.
dates.
And I don't see here either.
The age.
No. You know, the text after expansion and if it started, I don't see it.
No.
Okay.
It's supposed to be there. It was there. I swear.
Did you switch from Keynote to PowerPoints or made some changes when you had?
Well, it's supposed to be on Keynote.
That might be the problem.
It's supposed to be on Keynote.
Yeah.
But if they try to convert it into PowerPoint, probably everything went
Here
off.
we have Mac.
So we need the Keynote version,
È stato
otherwise
trasformato in
everything would be
PowerPoint come per gli
mixed
altri
up.
relatori?
Forse ora
È
stanno
un'altra versione. It's another version of Keynote.
Ma state avviandolo sul Mac ora?
Oh,
Okay. Maybe now it's been loaded on the Mac.
okay. Okay.
Much better.
Okay. Then we decided to treat the patient with a classic protocol, a Hyrax, which is our common expander, anchored on the E's and D's with the hook on the D in order to create a vector of traction that it would go through the center of resistance of the maxilla. I strongly believe in the use of heavy elastics, so 500 grams, 1/2, 14 ounces, and again the point of application in the forward part so that the vector of force would go through the center of resistance of the maxilla. The response would jump the bite. I don't use bite plates or bite razors. I don't need it because the typical protocol will create an increase of the lower anterior facial height. So in order to jump the bite, you don't need any of that. You can take a look at the facial changes that you obtain within a very reasonable time span. And if we look at the occlusion, we can see the changes introduced by our classic protocol, let's say. Initial rapid maxillary expansion plus face mask, end of phase 1. It took 10 months with this protocol. And we can take a look at the very significant differences at the occlusal level where we departed from a very severe class 3 malocclusion and we went to a fair class 1 relationship, molar and cuspid. The facial changes from the frontal, and most of all from the lateral, where we can identify the very significant profile changes in the end of phase 1. So just by comparison, we can take a look at the differences again, 10 months. And we can use that also in the mixed dentition, like this patient that has a genetic component. The father is a class 3 surgical patient of the office, and we see the functional deviation of the mandible according to a posterior crossbite and an anterior crossbite affecting all the anterior teeth. Again, a typical situation that we would approach relative to A and B, -9, which -6. There are no signs of dental alveolar compensation at this moment. The proclination of the upper incisor is retrocline, and again, we use a combination of a Hyrax on the 6s and Ds in this particular case. Once again, very important to have the hook in the front so that when we get an inclination of 25 to 30 degrees, we make sure that we are protracting through the center of resistance of the maxilla. I point that out because so many times I see the traction from the molar, which is an absolute mistake. So if we want to pass through the center of resistance of the maxilla, we have to have the point of traction in the front. If we traction from the back, no matter whether you traction directly from the molar or from a lever arm connected to the molar, again, you're away from the center of resistance of the maxilla, and what you get is a tipping back, is a backward inclination of the maxillary plane, minimizing the forward movement of the maxillary bone. So we get the diastema, the bite jumps, we get the resolution of the posterior crossbite, the anterior crossbite. Now a short time of 2x4 just to get the correction of the anterior teeth, and we can take a look within 10, 12 months of the differences that we were able to introduce in the face. Significant aesthetic improvement, again, 4 bands, Hyrax plus face mask. This slide summarizes the changes, forward and downward movement of the maxilla, clockwise rotation of the mandible. Very important to remember that the classic protocol introduces an increase of the lower anterior facial height, so the lower third of the face will be increased no matter what you do with the classic protocol. It's important because we will go back to that point later on. After phase 1, everything looks pretty much okay. Now we have positive overbite and overjet. Posterior crossbite was corrected. You can take a look at the differences that were introduced again with a completely conventional protocol within 1 year. Now, conventional retention, we just want to do the follow-up of the patient, see how the change goes, and observation time may be long because you want to go to the post-pubertal stage to make sure that your second phase of treatment is going to be successful or not, but stable. So we go to the beginning of phase 2, where actually, from the facial point of view, the results were very stable in this particular patient. And from the dental point of view, there's very little to be done because practically the occlusion settled down by itself. So there is no major correction to do. Only a very short time of fixed appliances will complete the resolution of the malocclusion. So we go directly to the retention period because the major issue is whether or not the results are going to be stable. So we want to see what happened 5 years after the second phase of treatment, and the face looks quite balanced. And of course, upon smile, all class 3s look more class 3. So here we reveal, chin is a little bit projected, maybe, but the resolution of the case is favorable. So we see a combination of phase 1, 12 months, phase 2, 8 months. And the occlusion is nice and stable through time. So if we look at the very significant differences, we may see all the benefit that was obtained from an initial orthopedic phase with a very limited amount of time of 2x4 braces and a very easy second phase of treatment. So the classic protocol. In terms of efficiency or efficacy, we're not going to find important differences, so to speak. So maybe it's applicability, the parameter that would make the difference. Applicability, understanding that is any of these protocols better than other? And I would focus on severity of the cases and facial pattern, because timing, I knew that was going to be one of the major issues approached by most of the speakers, so I wanted to focus on something else. Let's talk about severity of the cases first. If we're going to talk about severity, let's talk about severity. I think we all may agree this is a very severe case. Very severe case with very severe signs of maxillary hypoplasia and a component of a mandibular prognathism. The combination of both factors make this skeletal malocclusion very severe and very difficult to treat. The intraoral view reveals bad news because the malocclusion is also very severe from that point of view. As a matter of fact, we have a negative overjet of 9 millimeters. We have a class 3 of 10 millimeters. And from that point of view, I think we all may agree that severity of the case is an issue here. It was a syndrome, she was a syndrome patient. So there were some other skeletal malformations. As a matter of fact, she had some orthopedic surgery, and she was undergoing this kind of sessions of stretching the cervical spine because she had some problems of compression there with this kind of chin-cup extended device that would go to a pulley type of lever arms in order to stretch the cervical spine and decompress the medulla at that level. Probably that had to do with the limitation in the lower third, because if you look at the patient, there is a reduction in the lower anterior facial height. The lower third is reduced. If we take the condylium angle that Lorenzo exposed previously, this is not a high angle case. It's a short angle case. It's a short angle case for sure, less than 147 that just Peter Nang told us. But yet, it's a surgical case no matter what. And I didn't want to treat the patient. And I told the parents that I didn't want to treat the patient. And not to make a joke, but I was about to tell them, okay, she has so many surgeries, why not one more? But I wasn't sure about the reaction. But in my mind, it was the fact that she could benefit from surgery. And what was the major problem? Not to go to surgery just one more time throughout her life. But the family rejected the option. So I decided to do something I don't do very frequently, which is Alramec. And I did Alramec with a conventional protection face mask. I decided to use a protocol that is slightly different from the one that has been exposed here and from the one from Liu. Weeks 1, 2, and 3, I did 2 turns per day. Week 4, I started the face mask. Week 4 to 12, I went with alternative open and close of the screw. And I maintained the face mask for 12 months. Now look at the difference at the lip relationship after 7 months of phase 1, after 3 months of Alramec and another 4 months of protraction. And after 7 months, we got a reduction of 5 millimeters in the overjet. We went from -9 to -4, a still negative overjet. But I decided to keep on going, and I went until 11 months of protraction. And then incisors were in contact. 9 millimeter correction of the overjet. Yeah, the upper and lower incisors were retroclined, so I decided to make the decision to decompensate both arches and go forward with the upper incisor and go forward with the lower incisor, no matter what may happen, no matter whether or not I could jump in an anterior crossbite again. These are the progress records, and we're looking at a completely different phase than what we had at the beginning. This is a new patient. If we compare to the initial stage, differences are striking. And from the cephalometric point of view, differences are striking as well. So, at the end of phase 1, Alramec 11 months, fixed ortho for another almost a year, so it was almost 2 years of treatment altogether. And now we have positive overbite and overjet, and class 3 is now 2-3 millimeters. We began with almost 11 millimeters of class 3, and the exchange is going. We can take a look at the facial difference in the evolution of the case, but pubertal growth was not finished yet. So I waited until growth was over, and then we go to 15 years, 8 months. Now, the exchange has finished. What about the occlusion? Relapse. Big time relapse. Sorry, Lorenzo, this is one for your sample of unsuccess. Big relapse with open bite. Patient went back to class 3. Maybe not so severe than the one we had at the beginning, but still class 3. We have an open bite coming from the second molars, and the incisors are going into a barely edge-to-edge contact and trying to jump into an anterior crossbite again. So I have possible alternatives. Certainly one of them is surgical treatment. The other one would be camouflage. If I go with surgical treatment, I could decide between 1 or 2 jaw surgery. It would be debatable. Certainly a genioplasty, it would be a non-extraction case. But if we go to camouflage, I have to do extraction of the lower first bicuspids, and maybe to supplement my mechanics with skeletal anchorage. Again, they said no surgery, do whatever. If she has to stay like that, she will stay like that. But I didn't want her to stay like that. So something you have to make very clear to the patient if you're going to do a camouflage orthodontic treatment is that facial changes are not to be expected. If patient expects any facial improvement from camouflage orthodontic treatment, the patient would be disappointed and you will be in trouble. So make very clear that this is not to be expected, and not only talk to the patient, listen to the patient, and try to read in between lines whether or not the patient may confess it, but the patient may expect a facial improvement that will not come. So here we are pretty much closing the lower spaces. I decided to use 2 mini screws in the lower arch in order to run class 3 elastics, not from mini screws in the upper, just from the molars in the upper arch, just to maximize the forward movement of the maxillary arch while I was doing a space closure. Close to the end, the spaces are closed. I'm still running the class 3 elastics to the mini screws in the lower arch. Case was finished, and this is the occlusion I was able to get. Quite acceptable. In essence, I'm happy, patient is happy. If we look at the evolution from the cephalometric point of view, the big jump is between the initial and the progress after phase 1, where the skeletal changes are very, very significant. But at the beginning of phase 2, we have some relapse from the dental point of view and also from the skeletal point of view. Now the end of phase 2 reveals the dental alveolar compensation. Yeah, we were unlucky. There was a late peak of growth while we were treating the patient that jumped the mandible a little bit forward. So it's time to think, because we treated a very severe case with very difficult mechanics. It was extremely hard work. Yeah, the occlusal result was quite acceptable. The patient was happy, the parents were very happy, but what about the facial outcome? The patient is happy now. Will she be happy tomorrow? In essence, was the whole thing worthwhile? So applicability depending on facial pattern, and if we have to talk about facial pattern, we have to talk about the vertical for sure, because it's the most important dimension to the clinical orthodontist, because it's stable throughout growth, and because it's the last to end. And the craniofacial biologists have been telling this to us over and over again over the decades. So with very challenging facial types, what to do? Unusual forms of orthopedics. And I'll show you one case that is 2-in-1. Karina on the left of the screen, Carmen on the right of the screen. They're twins. Karina is a lighter case within the severity of the case. They're both class 3 dolichocephalic types, skeletal and open bite. In the case of Carmen, everything is more severe from the skeletal and dental points of view. We see from the lateral view all this convexity of the mandibular contour where there's no labiamental fold, where the whole thing is projected forward. And from the dental point of view, we see the severity of the class 3, more severe Carmen, again on your right. Open bite 5 millimeters for Karina, 10 millimeters for Carmen. Arches are normally configured. There is no maxillary transverse deficiency. From the cephalometric point of view, we may see that the mandibular plane angle is very steep. And I bet you that the condylium to mandibular plane is way beyond 150, which is -7 for Karina, -10 for Carmen. I decided to use a neutral bite block. I was positively surprised this morning by Roberta when she presented a bite block. This is a neutral bite block, and actually the aim is exactly the same that she presented, is to inhibit or control or limit somehow the dental alveolar vertical growth of the process, of the alveolar process in the back of the mouth, in order to have a forced contact all the time of the back teeth. And is closing the front so that tongue interposition may be blocked, and we can control the dental component of the open bite that way. Wearing time 16 hours a day, wearing time 12 months. Patient was extremely cooperative. The mother was a class 3. And when I told the mother, well, here we have a genetic component, because if you look at yourself, and she said, me? Not me. Wait to see my husband. So if your husband is even worse, then we have an even worse problem than I thought we had. So, but that redundant, very high level of cooperation, along with what? A chin cup. Yeah, I'm not crazy. A chin cup. I know I'm going to lose all your respect, but even in that case, I'll have to present it. Customized of leather, starting with 350 grams, going to 500 grams. Again, I use heavy forces in orthopedics, always. And wearing time, I started day and night, and then nights. Here she is. After 8 months, the dental changes are very significant. Bite was almost closed in Karina. For Carmen, there was a reduction of 5 millimeters in the open bite. Profile looks the same. If you want to expect facial changes with chin cup, you have to wait for a long time. But from the dental point of view, the situation was improving greatly. So the resume was that I started with a bite block. Then after 3 months, I started the chin cup, bond the upper incisors to get a control of the upper anterior teeth. Wearing time was 23 months. And I maintained the chin cup until puberty. Now the face is, in the progress, is changing, especially for Karina, where we see a fair amount of facial changes. Again, Carmen looks very long and very severe. But from the lateral point of view, Karina is going into a class 1 skeletal relationship. In Carmen, the profile still reveals a lot of signs of class 3, but we are in the way. From the dental point of view, we were able to completely close the bite and completely correct the class 3. So, yeah, there's signs of dental alveolar compensation in the lower arch, but bite is closed in both patients, and we are class 1. So at the initial, we have the 2 twins. Then we started phase 1 with the same protocol for the 2 of them. Then from here, the destiny for Carmen and Karina was different. Carmen, if you know the opera, was meant to have a fatal destiny. Not so fatal. But I started the second phase when growth was over. And it was Carmen with, yes, several signs of class 3, strong chin, still a long face. She evolved to a major discrepancy in the upper arch with the cuspids erupting buccally. So at this point, I decided that open bite plus such a extreme degree of discrepancy resulted in a full bicuspid case. So I did upper second, lower first bicuspid extraction, and here we are close to the end. Go to the retention phase. What does she look like when she's almost 22 years old? Yeah, you would say, well, I can see the class 3 skeletal pattern behind that phase. Yeah, but that doesn't have anything to do with the situation we had at the beginning. Especially if you look at the evolution of the phase. But the major difference was done in orthopedics. Now, from the occlusal point of view, the result was acceptable, was okay, was good. Nothing to say about it, but look at the differences from the skeletal point of view. What about Karina? What about her? It started at the same time. This is Karina, beginning of the orthodontic treatment. These are the changes between the initial stage and the end of orthopedics. Wicks was reduced by 6. And we go directly to the end of the orthodontic treatment because we have no much time. Beautiful smile. Now you tell me, if you look at the profile, and you can guess, we departed from a very significant class 3 skeletal relationship. If I hadn't shown you the first picture, you would never guess. Not only that, we were able to treat Karina without surgery, without skeletal anchorage, without plates, without mini screws, without extractions. Without extractions. And you can take a look at the difference and see that the occlusion was good, was nice, was acceptable. The end of the orthodontic treatment, where at least I'm pleased with the profile. And if you look at the cephalometric evolution and you go to the final stage of orthodontics, you will not see any significant dental velar compensation. Upper and lower incisors are pretty much within normal limits for that facial type. Was she dolicho? I bet she was. She still is. And retention, keep on smiling. Evolution, now the patient is almost 20 years old. And the occlusion looks like that. And you can take a look at the difference from the position where we departed to the final occlusion. So unusual forms of orthopedics that can be something so sophisticated as a chin cup and a bite block. And then orthodontics. What about stability? Okay, some of the people that have done the greatest studies about stability are in this session, so I wouldn't dare to say anything, but just wanted to mention this article because it's just out of the oven. It's from the Spanish group in Madrid, in La Complutense, and they did a study at 10 years. But it's been documented that dental changes or dental velar changes are stable over time in patients treated with classic protocols of early treatment of class 3. So it's nothing new, but it's nice to have the data. It's nice to have the data because now I'm going to steal from Marie, no steal, because I asked her permission. But the meta-analysis that she presented recently in a webinar, I think is extremely important. It's been mentioned before. I think it's important because of the data, and it's important because of the honesty. Because if you are the mother of the child, like Marie is the mother of the skeletal anchorage with the Hugo de Cler protocol, you have to be very honest and very brave to say what Marie said during her presentation. The first thing that strikes me here is that these are the articles included in the meta-analysis. Rapid maxillary expansion, more than half of the articles reported by Marie did not use rapid maxillary expansion, in clear contradiction to the classic notion that you have to loosen the maxilla in order to enhance the protraction of the maxilla. So are we facing a new paradigm or a new dogma, and I'm not aware of it? Maybe that's the case. And out of the articles presented, only 3 of them use Alramec. One of them, the one from Giuliano. Great article, Giuliano. Congratulations. When it comes to long-term retention, it's been mentioned already, but there is no data. So we may anticipate cases treated with skeletal anchorage will be stable. We may debate they should be stable. They probably will be stable, but the fact is that we do not know whether or not they are stable, because there is no long-term data. You may say, yet, we will find out very soon. Well, that would be when it comes. Now, today, we do not have the data. And thinking about long-term, and Lorenzo is here, Tiziano is here. Vertical is a major issue, and growth in the long term is a major issue. So stability and retention, Marie says, I do not add anything. She says, bone anchor face mask, similar to conventional face mask therapy. All class 3 elastics, maintain mini plates and elastic until growth has ceased. Is that a sound strategy? Then in summary, efficiency and efficacy, back to Marie, comparison, 0.2 degrees in A and B, 0.9 degrees in the width analysis. Now if we go to class 3 elastics, bone anchored, 0.6 millimeters in the width analysis. So in terms of the surgical effect, what's the difference with conventional face mask? Because if there is no difference, there is no reason to do mini screws or skeletal anchorage. I mean, it has to be proven that there is a significant difference in efficacy or efficiency in order to justify to do early treatment in very young children. Otherwise, it's over-treatment. So that has to be proven. Otherwise, we have an ethical problem there. But regarding the vertical, we have to admit that if it is true that the vertical is better controlled with the skeletal anchorage, then we have room there for an indication, because we all know that there is an increase of the lower facial height with a tooth-borne face mask. So in terms of applicability, maybe for those patients with a long face would be clear indicators for use of skeletal anchorage. Then facial pattern may be an answer. Timing may be another one. Bone-borne appliances work better in dolichocephalic patients. In terms of stability, I'm sorry, but we have no data to compare. So I'll leave you with a trembling question mark. That's what it is. That's the way it is now. So I would like to thank you very much for your kind attention. Grazie, amici. And since I'm an elegant person, I have to say, felicitaciones. Campione. Ma ci vediamo alla prossima. Ci vediamo alla prossima. Forza Italia.